So it's always a challenge being the opening speaker in the opening session of a congress, and it's made me realise there's quite a lot of navigating of this building that the attendees are going to have to find, and hopefully we can improve things. And I'm very glad to see my colleague Elhami from Cairo. You found it too. So this was a title that I was semi-given, negotiated with the committee as being something to talk about. It's very nice that I think you all assume I have had a successful career, and I think that as I come on to, one of the first things one has to do, I think, is define what success actually means for you as a person and for what you're trying to achieve in your life. So first of all, I have the only conflict of interest or conflict of disclosure potentially is I'm a trustee of World Child Cancer. I have some other conflicts that you ought to know about. So I still have a real passion for understanding Wilms tumour. I am extremely upset about Brexit, which hasn't stopped from the day I heard the news in June 2016 when I physically felt sick when I turned on the radio in the morning and couldn't believe it. And we are still in this crazy situation, and I can only say sorry to our friends in the European Union about the mess we're calling. And most importantly, I want Wales to win the Rugby World Cup, and that's fine, the semi-finals this Sunday for them. I know this is England All Blacks game the day before, but that's much less important. No rugby fans. So I thought I would try and not have too much data, try a bit Pecha Kucha, which is what my children all seem to be doing in their jobs these days, talk to pictures and feelings and emotions and engage the audience. But I thought it might just be helpful to have a little list of the types of areas I want to cover. So I think to know that you failed, you really have to know what it is you've been trying to achieve. And failure, of course, all these things are relative and nothing's ever black and white. I thought it would be helpful to show you a little timeline of my career since I left medical school. And then I'm going to cover some of these following points about if you're really going to be successful, and you will inevitably then have some failures along the way, you've really got to be wedded to what you want to do. But there is this balance of curiosity versus sort of overarching ambition that nobody else is going to get in the way of what you're trying to achieve. Team science, an ever-increasing concept, and I'll talk a little bit about the trust equation, because choosing your teammates is very, very critical, I think, to succeed. This one I'm very bad at, the work-life balance. You need to learn to say no. I'm still learning that one because I tend to say yes most of the time. You certainly need to pick your battles, and sometimes you have to just appreciate that something is not worth pursuing anymore, and that even if you were to reach what you'd call success, perhaps it's not worth the effort. And I think you have to really stick with being patient-centered. To do anything that's effective and leave a legacy, you must finish. You must finish a job, you must make it public and accessible to those around you and those who will follow you. And of course, I must finish with a little joke about Brexit, because it's still not over. So I suppose one of the first things was that I, from a very early days in my career, knew I wanted to combine genetics with medicine. And I think that's probably very helpful in building a successful career, is to know what it is you want to do. And that was really where I sort of interfaced with pediatric oncology. I like looking after children. The biology of molecular understanding of the basis of disease was really just opening up in the early 1980s and starting to influence clinical practice. So that was a nice direction of travel. On the left, you'll see the sort of types of jobs I've done. So I did general pediatric training. I spent a small amount of time in Australia. I had an MRC, it was then called a recombinant DNA training fellowship, which I did in Edinburgh with Nick Hastie at the MRC Human Genetics Unit. So this was then the first failure, really, was getting the postdoctoral grant funding. So the first job I applied for after my PhD was what was called an MRC. In fact, it wasn't called an intermediate clinician scientist. I can't remember what it was called, but it was effectively a grant aimed at individuals who are just postdoc. And that's been a big hole. And when I was in that position, there wasn't a career structure. Now we do have that type of funding in the UK, and I don't know how it works in other countries, but this is a critical, if you like, drop-off point for many people. And I applied for this post, I remember going down to MRC head office in London to be interviewed by this sort of huge room of 25 people. And they said to me, I explained I was going to do a 50-50 job, carry on my clinical training, carry on doing a lab-based project over shock horror, the other side of the city, which you could actually cycle across in 20 minutes, and I did it every day. And there was this kind of sharp intake of breath around the table. They thought these clinician scientists were people who'd just been in the lab all the time. But actually, in the exam book, it did say they could be 50-50 split. Anyway, I didn't get the job. And then that led to me, fortunately, Cancer Research UK at that time would consider a project grant application from someone who'd just done a PhD, and it could also include your own salary. So I think that's the first positive learning point. Try and get funding for yourself, because then you're much more portable, you're much more in control of who you work for. And that enabled me to identify a fantastic mentor in Ross Pinkerton, and move down from Scotland to work at the Institute of Cancer Research with its allied partner hospital, the Royal Marsden. And at the time, I guess there were not that many people working in paediatric oncology, and I was able to get a tenured clinical academic post relatively straightforwardly. But then the next crunch came in keeping that post, because that term tenure used to be you stepped into it, you could sit there and probably do nothing for the next 40 years and you hardly ever got thrown away. But these days, unless you get money, everyone's under every 5-year review, even if you've got a tenured post, and it's really important that you can bring in significant funding. And I found at that sort of second crunch point in my career that had a really enjoyable time for about 18 years, but it was really hard to keep the money coming in. And so at the final change in my career, which was 9 years ago now, I moved from a very active clinical practice into, taking on the role of medical director for an entire cancer network serving 3.5 million people for cancer at all ages. And that was quite an interesting change of focus, but I've never actually stopped also being interested in renal tumours. Now, on the other side, so these are all the jobs I've done that nobody pays you for. And probably part of the reason for that semi-failure over there is because I was also doing all of this over the years. But I think getting involved very early on with your national children's cancer society is really important, and you can never be too young to do that. I think once you know you want to be in the field of childhood cancer, whether you're a radiologist, surgeon, oncologist, whatever, be an active an enthusiastic member of your national children's cancer organisation. And I think more and more now every countries have those, and if they don't, you should be working with your peers in your country to try and help establish one. So that led to me being chair of our National Renal Tumour Study Group, and then taking us into realising we'd come as far as we possibly could with national trials. So we then joined the international studies of the SIOP Renal Tumour Study Group. There was an opportunity to join the SIOP Scientific Committee. So I was actually chaired this committee for 3 years, 2002 to 2004. That was a massive job. And I think that sort of coincided with some of these grants, and it was quite hard to do both at the same time. But out of that emerged the fact that clinical trial leadership, we had the European Clinical Trial Directive coming into play, and there was a whole question about who's responsible if something goes wrong when a child's been treated on a clinical trial protocol that's effectively standard of care. So it's not, I think early phase studies, it's very obvious that you have to have a sponsor accepting risk. But when the therapeutic question is about optimizing treatments that the child could be given anyway as standard of care, it became much more complicated. So I was asked by SIOP Stroke International to work with the SIOP Europe group to establish what we call the Clinical Trials Committee. And that's to try and work out how we would approach having a SIOP label on studies. So I've then worked with SIOP Europe for many, many years in various roles on the board. And I think the biggest achievement, because I hope I'm allowed to talk about some successes as well, was the fact we were able to secure this 5-year funding from the European Framework Programme 7 to build a European network of excellence for cancer research in children and adolescents called ENCA. And that has really allowed SIOP Europe to blossom and become the very well-established organisation it is now for the continent. And as you know, I'm now President-elect for SIOP again, and about to take over from Eric Buffet later this week. So that's my timeline, and I think I just really wanted to point out these kind of crunch points, which I think everybody faces, is that transition after your PhD or research period, and then actually sustaining that joint balance between clinical medicine and securing ongoing resources to do your research. So this was London 2012. We had the SIOP meeting in London when the Olympics were on, so we had an Olympic torch, but I think you have to be clear yourself, what is success? It was actually fantastic to welcome everybody to London at that time. Now here we have the smoothed trends in 5-year survival for children in England over the lifetime of my active consultant career, I would say. So we've gone up about 1%, it gets better every year. So in the last, between 1990 and 2015, it's gone from about 70% to almost 85%. And that's the breakdown by age group. And I suppose we're all trying to make a contribution to the continuation of that curve, but we also know that survival's not enough. We want good quality of survival. We want to cure children at least cost. And probably the field that I've toiled in my research career has been very much about optimizing therapies, because it has in fact been very hard to identify novel therapies in children with Wilms tumor. So I suppose I might claim a little bit of success to this almost laser point difference, but this is survival from Wilms tumor in England, again, from the National Cancer Registry. So this was really just as we were getting started with changing to the pre-op chemo approach, and now the last 2 successive 5-year periods, we've had our survival rates continue to go up. So very early on in my career, when I was what called then a senior house officer, I remember Professor Al Ainsley Green in Newcastle saying to me, "You've got to have fire in the belly if you're going to do research." And I'm sure probably everyone in this room would agree with that, because at the end of the day, clinical practice happens all around you, and the children are there and you need to treat them. And whether it's you or somebody else doing it, the work goes on. Research, if you don't do it, it doesn't happen. And you've really got to have a lot of self-motivation and be prepared to put in a lot of discretionary effort. But I think it's also very important, if you're going to be successful and really enjoy your career, that you have self-awareness. Coming back to Al Ainsley Green, I remember him implying that I was perhaps a bit too noisy, talkative, argued back. I can't remember the exact adjective he used, but so I obviously didn't have that great an impact. But you might think you're a nice, cuddly, friendly person, but actually how do other people see you? And I think it's really important to stop and reflect about how you and the way you're going about your research impacts on other people and those around you. And that's true not just in research, but in your clinical practice and working as part of an MDT and so on. And I think in an ideal world, you should set aside some time to self-reflect on quite a regular basis, not so much about your clinical practice, that's also very important, but about how you're leading your own professional life. Now, team science, okay, anyone spot me in the boat there? But this is, when you're rowing, it's a very, very focused goal. Everybody's got to pull their weight equally if you're going to get over the line, hopefully first. But there are all sorts of different types of things you do in research where you need a team. And it may well be that if the ultimate goal is to design a new drug for a very rare type of childhood cancer, that you're happy to be one of the people just helping get things to first base. So again, coming back to what is success, I think spending a bit of time to decide what you're trying to achieve for you personally, your contribution to an ultimate goal is very important, because there's nothing more frustrating than setting out to do something and actually not achieving it. And much research now, especially in the field of big randomized trials, big genomics and so on, you can't achieve on your own or even in a very small team. You've got to be part of a big Himalayan-style expedition. So this is something that only really I became aware of in my medical director days, but I think it again applies everywhere. It's really important in your team that you trust other people. And there is this thing called the trust equation, where it's how good you think somebody is, their knowledge and how reliable they are if they say they're going to do something, times or plus how often you meet together socially. And then this is the important bit, is really then you divide it by how much you feel they're only motivated by self-interest. They haven't really got a common interest in delivering the goal for other reasons. And whilst I'm not suggesting you dissect every relationship you have in life professionally in this way, I think when you're thinking about do you want to collaborate with people, pick your partners, invite people to be part of your team, or think about are you going to accept an invitation to collaborate. These elements are very important. And one of the things we realized in building teams in North London in adult cancer, where often institutions have been historically competitive with each other, and now we were trying to get them to think differently, was one of the biggest barriers to making progress was this. They only knew each other as competitors across the other side of the table or the other side of the conference hall in an academic meeting. And they were always criticizing each other rather than coming together around a common endpoint. And that was something that I think took some time to build. And this could be Lyon. I think this is more likely to be British drinking habits. But it is important to make some time to socialize. Doesn't mean you have to be best friends with your team and the collaborators, but I think it is important that you make that effort to meet face to face and have some downtime together. The work-life balance, you're all treading it right now. It's very, very hard, and I think the learning point for me is that I have often taken on far too much, and that does then slow down your ability to deliver things and also be successful in winning the resources you need for your grant. But if you have a reputation for always saying no, people will stop discussing things with you and they won't ask you. So it's a balance you have to find yourself. But I think it's a very important one to be, to be aware that you have to make these choices. Now, this is a fantastic photograph, I think. Wildlife Photographer of the Year at the moment. This is a marmot. I saw one of them this summer in the French Alps. And you can see he certainly wasn't expecting to see this fox around the corner. But I think you do have to pick your battles if you're going to come through unscathed. And some things are just not worth fighting for. And so, sorry, this was a bit wordy, but I just wanted to reflect. I was asked by the chief exec of the Royal Marsden back in 2004, so I was a relatively new consultant. Well, actually, no, I've been a consultant for about 8 years, but I still felt a bit junior. Yeah, why don't you get on and canvass the views of the adult teams about having a teenage unit in our hospital? And I was perhaps a bit naive. I thought, well, it's really important that we should have a teenage unit, so I'll take on this task. So I created an email to send around. And this is actually what was in the email. We would like to canvass your views on how you would wish to use a teenage cancer unit for your patients in the teenage age group. suggesting two options, that they either would maintain overall consultant responsibility for the patient, but liaising with the staff grade or the doctor on the unit, or would they just bring their medical opinion, but the actual day-to-day management of the patient would be decided by a specialist consultant in teenage cancer. And the nursing staff on the unit very much, or the proposed unit wanted option B, which was they wanted to have a medical team to go to round the clock who knew the patient and who was empowered to make those management decisions. So these were the answers. So it caused all sorts of paranoia reactions from the adult medical teams and a few quite considered discussions. And this was a fairly typical thing, no discussion on this, I just remain in charge. And then we had much more nuanced people. So the urologists actually said, yeah, we discussed your letter, we've thought about it a lot, that we consider patients aged 17 or more should be regarded as having adult tumours. It's an interesting definition of adult tumours rather than biology, as perhaps we'd look at it now. And of course, a good point that this would be for testicular tumours, that the overall management should be part of the super-regional network for testicular tumours. But they did appreciate the advantages of being treated in an adolescent unit for such patients. It was about another 10 years before the Marsden actually had a teenage unit. By that time, I'd left. So this was a battle that I was sort of put into at a relatively junior stage in my career, and then realised I was probably being put out as the fall guy. And it certainly started the conversations, and it was the obvious thing to do, the right thing to do for patients, and it did eventually happen, but it wasn't due to me leading it. So I think two things. You have to have a very thick skin and do not take these criticisms personally, because often it's not about you, it's about change that's going to impact other people. And I think the best way to survive this is, apart from not taking it personally, is to stay patient-centered. Because if all your arguments about why you want to do something, it's about the patient benefit, it's very hard for people to argue with you. The way they will argue with you is on subjective, descriptive grounds. And you have to keep coming back to, well, what's the evidence for why we need to make this change? And that's easy if there's good evidence, but most of the time there isn't good evidence, and that's why we are here doing research, because we need to build the evidence base. Just to finish up on the pick your battles, stay child-centered. There is literally hundreds, thousands of research areas to go after, not just to do with biology, but optimizing therapies. So find the thing that really floats your boat, gives you that fire in the belly, and stick with it. Now, it's very important if you're going to have an impact, and also I think feel satisfied, is that if you take on a task, you must finish it. I'm sure you've all had training in your career about the sort of types of personalities people are, and not everybody's a finisher, and if you're going to have a good team, you need people of different personality types. And lots of us in research are more like the hare. Oh, it's a great idea, let's go do this. And then, oh, here's another great idea, let's go do that. And the person that just sticks with one thing that they think is really worth doing gets it over the line. I'm probably more hare than tortoise, but there are some things when I've known we have an evidence base that we do need to get on and do it. So I was reflecting through some old papers that I was sorting through the other day, and I'd had correspondence with David Machin back in 2007. So he's a very senior statistician in the Children's Cancer and Leukemia Group, now retired. But we were discussing about whether biopsying renal tumours was a potential clinical risk, and did it increase risk of local recurrence. And we had lots of arguments in both directions. Our colleagues in North America, if a renal tumour is biopsied, they consider that is equivalent to tumour spillage and call it stage 3 and treat appropriately, which of course for Wilms tumour, that's a really bad thing if you need radiotherapy and anthracyclines. Our colleagues in continental Europe generally did not biopsy at all, made an empirical diagnosis, but in the UK, because we had had concerns about giving chemotherapy to children who may not have had cancer, we wanted to carry on biopsying patients. So we had done this randomized trial in the UK between 91 and 2001, so it took 10 years. It was called UKW3. And in it, any patient with a localized renal tumor that the surgeon felt they could take out that same day if they needed to, was meant to be offered randomization to either have an immediate nephrectomy or to have the European SIOP approach of pre-op chemo and a delayed nephrectomy after 6 weeks. But because we wanted to ensure that we had histology, it was recommended that every patient going down the delayed nephrectomy route would have a biopsy. So that has been what became our standard of care in the UK for 20 years, effectively, from 1991 till just relatively recently. We have always biopsied all renal tumors before starting chemotherapy. But I think it's quite interesting, this conversation. So I've had this concern for a number of years, and I'm still not completely sure that we've answered it. But the thing is, in this study, about half the children did have a biopsy and half had an immediate nephrectomy. But they weren't all randomized. Only a small proportion of those patients were actually randomized. And so the question was, can we, if there is more relapse in the group that had a biopsy, are there clinical reasons that may explain these results to some effect? And the thing was, this was the maximum data pool we had to work on, 635 patients with unilateral Wilms tumor, and only 50 events relevant to the analysis we wanted to do. So here we are, finally published in 2015. So it took a long time to work through these analyses, decide if we were confident in the results or not, and publish them. But the conclusions really were that on univariable analysis, biopsy, anaplasia, and tumor size were associated with increased risk of local recurrence. But on multivariable analysis, only the anaplasia and tumor size were important. But the p-value and the hazard ratio for association of local recurrence with biopsy was still 1.8, and you can see the confidence intervals almost up at the level of 1 to 3.3. So we remained concerned. So what do you do about it? Do you change your clinical practice, or do you try and do more research and investigate it further? So in this SIOP 2001 trial, which by this time we'd completed, we had almost 5 times as many patients as in UKW3 in exactly the same category, unilateral Wilms tumors treated with pre-op chemo. And there were 139 local recurrences, so almost 3 times more. And we repeated the exact same methodology that we'd applied to the UKW3 data set and came to this conclusion, that the hazard ratio for the association of local recurrence with biopsy was not significant, but the hazard ratio is still a bit over 1.4, but the p-value is much, much less significant. The trouble was, we just couldn't get this second, much higher quality analysis published. And I don't know if you still all read Peanuts, but, you know, Peanuts is forever trying to write his book, get his book chapter published, and having dialogues with editors. So we submitted this in 2016, and it spent about a year in review with JCO. They asked us to do all sorts of new statistical analyses, which we did, and then this was the final conclusion. We just could not convince the JCO editor that our paper was worth publishing, and the irony, I think, was that they had concerns about the usefulness of the results to oncology practice, and yet this is a decision in your clinical practice you must make once a month, probably in most big centres. You've got a renal tumour, does it need a biopsy, yes or no? The good thing is, with some determination and with help of Sabine Irtan, the French paediatric surgeon who was working with me at the time, we did eventually manage to get it published in another journal, and it came out in EJC this year. But how did we actually use this data? And in fact, Tom Jackson, sitting in the audience, did this work with me. So we decided to say, well, we should probably, although we haven't shown a significant association of biopsy with local recurrence, we should probably reconsider doing it routinely, because there probably is a small risk. We just can't be absolutely certain. So we decided to look at it. Unlike with Brexit, that actually in the UK we wanted to change our practice and be much more European and stop doing routine biopsies. So we said, well, what's the age cutoff? So we looked at the population level incidence of renal tumours of childhood, working with Charles Stiller in our National Cancer Registry, and found a cutoff of about 10 before Wilms tumour fell below a relative proportion of 90%. So we actually published some national guidelines for that. But then 2 years later, and this is the other important learning, I think, is one has to be prepared to change your mind. So you might think this is a fairly trivial thing, to have an age threshold of 10 versus 7, but just recently I've been working with Keio Nakata, a Japanese epidemiologist, and she's been analysing the entire global incidence of renal tumours of childhood, and she has a poster here tomorrow, and this type of data is in there. And what you'll see is that actually, if you want to avoid giving chemotherapy to a child who probably has an RCC, that the age threshold of 10, and this is in Caucasian populations, is probably too old, and that we should go back to doing what SIOP, in fact, have been recommending for a long time, which is an age of about 7 years old. So change your mind, use the best data you can have available to you, and be persistent in being very thorough how you evaluate the data, and once you're confident in your conclusions, do try and make the effort to get things published. Now, there are some questions for which maybe there are no answers, or certainly you're not going to have access to the data sets to provide the answers. And one of these is the moot question of whether older age is an adverse prognostic factor in Wilms tumour. And we've been looking at this, thinking about this for over 20 years now. And I think we probably still don't have the answer. So Jana Hall in Utrecht recently analysed the big data set that the SIOP Renal Tumour Study Group has. And we can't really pull out age separately in multivariable analysis, even with a very large number of patients. So maybe this is something you just have to keep under review, or you have to say we have to take another approach, and that fundamentally it's going to be the biological subgroups that will tell us who needs more treatment and who doesn't. So we've got to come back to Brexit. I went to the Hay Book Festival this summer rather, and there's a great book of Brexit cartoons, and I'm someone, I really love cheese. So this, really struck a chord to me. There's this fantastic opportunity of working and maturing together, and unfortunately, our current political system has taken us away from that. But that's just politics. You're in this room because what we have a global problem with childhood cancer, in that incidence is rising. There's very large inequalities, and these are population-based incidence and mortality data from IARC. We're going to be hearing from the director in the first keynote lecture tomorrow. But what you can see is in high-income countries, there's not so many of the world's cases, and hardly anybody dies. But you come to Asia and Africa, most of the world's children live in these continents, and unfortunately their survival rates are still nowhere near what we know is achievable, even with relatively simple treatments, diagnosis and treatments. So it's fantastic that you are now in the middle of your careers at a time when the World Health Organization has shone the spotlight on childhood cancer right around the world. And you need to use this focus to the advantage of getting on with your career, and hopefully being able to be part of mobilizing resources, both money, people, well-trained people, research that's relevant to the challenges in your own country. Because WHO is saying that they want to see at least 60% survival rates for childhood cancer overall in every country in the world by 2030. That is a huge ambition. I'm glad to see Train Israel is here, who's been driving this for renal tumours and supportive care in Africa. And it is true that with the current state of knowledge we have now, the majority of common childhood cancers can be cured with relatively inexpensive treatments that can be given in an effective and safe way. And of course, you will get children who hopefully will have many decades of life to contribute to their own self-fulfillment and their society. But you can, please do take every opportunity to hear more about this during this Congress, and also to establish future friendships, future networks that will help us achieve this goal. And thank you all for listening.